So welcome back to the Science of Teaching movement with myself, Lincoln Blandford. Now, in this particular episode, we have an excellent opportunity to talk to Mark Comerford, who is going to be exploring some of the history of kinetic control. In fact, Kinetic Control reaches its 30th year in 2025, and Mark takes the opportunity to talk about the history of kinetic control and also some of the research that's led us to this particular point. Plus, he gives us some ideas about where things are going next. So this is split over a few different parts, 3 different parts in total. And I really hope you enjoy this chance to hear Mark talking all about kinetic control and much more. Mark, so good to see you. We are talking today based on this idea, this theme of 30 years of kinetic control. So just saying that's a massive achievement for KC to reach this particular landmark.
Yeah, I'm pretty proud that we're still going.
And that you're still going. So I mean, obviously you've seen a lot of change in the world since 1995. So it's going to be good to sort of dig into a little bit of the history of KC, but also where things are now, where things are going. Before kinetic control, there was a certain period of time when you were going through education and then starting to deliver education and then work clinically. So it'd be nice to sort of hear a little bit about what was happening pre-KC, because there was certainly some significant history there.
I think, because it's interesting that, I was one of the people who, when I was a student at Queensland University, we were actually given a bit of the whole idea of the Vladimir Yanda's work on this, like the postural and phasic muscles, and it sort of was a bit of a new thing then. And as a student, we just thought that everyone thought that. Then after it took a while to work out that actually, not everyone was getting this idea. And then several years later, when I was working at the university, part of my role was the movement and muscle exercise training. And so, because prior to this, basically physiotherapy and a lot of the movement science sort of stuff was very much stretch and strengthen. If something didn't move enough, you stretched it or mobilized it. And if it didn't work hard enough, you strengthened it. So it was all about sort of, restrictions and atrophy and hypertrophy. And then, this sort of stuff started looking about how the idea that there might be synergists that have coordination rules. And that's what we'd call it nowadays, but that's not what it was thought about then. And so we were sort of doing that at the time. And I had the what I thought was remarkable luck to be teaching at Queensland University when Vladimir Yanda came out and did a sabbatical. And so I got to actually teach prac classes with Vladimir to students. And so I sort of got a bit of a real understanding of it then. And then what made a big, but the Yanda approach was very much at the time, we're looking for the restrictions. So the short overactive muscle would be mobilizing restrictions. And then if the movement control didn't come back, you'd do some strengthening work. So that was very much, Yanda was very much a stretch and strengthen, but he had a novel way of looking at the restrictions and looking at trying to get them going rather than also looking at compensations for them. Then Shirley Salmons was the next bit. That was the missing piece of Yanda's puzzle at the time.
So just before we get into Shirley and start exploring that component, just give us a context of what years we're talking about here. So what sort of, just so everybody sort of knows what sort of decade or years we're describing here.
Yeah. So we're talking 78, 79 in particular. That's that sort of time. But I was a student in the, I was a student. I was a student in 77, 78, 79. That's when we first got about it. But then I was teaching at the university in 88, 89. So there was a 10-year period where we did quite a bit of Yanda sort of stuff, and it was very much a little bit of that, but it was very ad hoc because not everyone was routinely doing it. But then by the time I was at the university, we started to become part of the curriculum.
And when was Yanda's sabbatical?
87, 88, I think.
Right. Okay.
Yeah, I can't be sure of that, but he was out there again, and because Jo Bullock's actually did her PhD with some of his stuff there too.
So by the time, so you sort of graduated late 70s, early 80s, then you sort of moving into clinical practice.
Yeah. So I was working. So I graduated in 1980. So we used it clinically, and was a bit of it was still very much stretch and strengthen. Yeah, clinical reasoning didn't exist in those days because we had so few tools clinically to use. We'd mobilize, joint stretch things, strengthen stuff. Do a bit of cardio. We didn't need clinical reasoning because trial and error was sufficient. If this didn't work, you tried one of the other three things that you had in the toolbox.
Yeah. What's left? Yeah.
Exactly.
So you've got a sort of decades worth of sort of going through that education, starting to work clinically. Yanda arrives. You get to see some of that way of considering muscles roles, that sort of way to classify.
Yeah.
And then you started talking about Shirley there.
Yeah. Because Yanda would look at movement and look to see this muscle's dominant to that one. So mobilize them type muscles dominant to stabilize. And he called them postural and phasic, which got quite confusing because the way he termed them didn't sort of match the way we'd naturally think of them. But it was basically two joint muscles were tight and overworking for low load function, and when the other stabilized the muscles, the one joint muscles weren't doing their share. And he came up with what he called the upper and cross lower syndromes. And I've done some work recently where we just based on how muscles have changed. How we understand muscle. So upper trapezius used to be immobilized, and now we know it's a stabilizer. So I've done some work recently in some of the courses of rewriting Yanda's upper and lower cross syndrome, and putting the muscles back in their right boxes, sort of thing, and adding because that was for the head postures and the lordotic posture. And I've actually done one now where we've actually modified, done what for the sway back posture. So the upper cross, lower cross, the lower cross syndrome was based on a lordotic kyphotic posture, and didn't include the sway back posture because it wasn't common when Yanda was developing these. So I've actually made one up for the sway back posture as well. So we have three boxes now, based on Yanda's terminology and thing, but just giving muscles in the right places. And then
so that classification then based on their roles and also the multifactorial classification model, where they're best placed within that framework.
So and reworking. So Yanda's model was very much based on the muscles that change with postural change. So the head forward chin poke posture, and then those are the short muscles, long muscles, that the short mobilizers and the long stabilizers that associated with the head forward chin poke posture. And his lower cross syndrome was all based on the lordosis kyphosis posture and the anterior tilt, and that was then based on again looking at that posture. So Yanda's classification was based on sort of postures of the time, and then but the sway back posture, which is the most common posture nowadays, wasn't included at the time because it wasn't common at the time when Yanda was developing that. And so I've done the same thing. I've put Yanda's head on my shoulders and said, as if he would have done this, and then done the same thing to the sway back posture, looking at the sort of those changes that go with that, and so not called it the lower cross syndrome, just called it the sway syndrome.
Okay, so sort of channeling Yanda there in terms of reworking that model. It's interesting as well, you're describing the times and environment have changed how posture now presents. So you're seeing sort of some interaction there with the environment and task, perhaps?
Exactly. Yeah, so the postural change that has been significant in that period of time is that we're now society of sitters, and we stand still and hang on our hips as opposed to walking around in lordotic postures all the time. And the upper body, the head forward chin poke and drop shoulders forward, protracted shoulders, is still relevant because that's where we spend all of our time sitting in front of a screen.
Doing something like we're doing right now. Okay.
Yeah.
So you then started to talk about the work of Shirley Salmon.
Yeah, so I'd never heard of Shirley, but I was at the one of the conferences in Australia, and Shirley was the keynote presenter, and Carolyn Richardson was sitting beside me, and because Carolyn and I were people teaching the Yanda framework within the movement and exercise training programs at UQ, and we're sort of sitting listening to Shirley talk, and I'm going, she's got a big shovel and is filling in the holes in the Yanda approach, because Shirley's approach was looking at not so much the restrictions, because her background was neuro, and she was looking at movement quality and movement patterns, and her approach was not to sort of mobilize the restrictions, but to look for where the compensations for the restrictions were and teach people to try to control those compensations. And so she was looking at the combination of what she was called a movement system investigation sort of pattern at the moment. But But what she was really talking about was looking at, and the way that she was doing this was usually looking at people controlling what was moving too much, okay, while they're doing that. And then, but that was one part of her process is, yeah, where you hurt, stop moving there while you move somewhere else. And that was one of her famous sayings, you know. Yeah, well, it hurts when I do this, but well, don't do that, you know. And if you see someone flex too much, well, don't do that. And that sort of came a bit of a catch cry, but it actually was very, very observational and worked very well. But the other thing that she did also, which she just blended in together because that's the way her neuromind worked, was that muscles that were not efficient were too long usually because they were posturally long to a large extent, or they were pain inhibited. But then she was trying to make them work in their shortened range. So not make them stronger like everyone else was doing. Shirley had this novel idea. If they're long muscles, we don't need to make them necessarily stronger per se, but we need to make them work in their shortened range so that they could help control this excessive movement. And so those two philosophies she blended together. And then so I then spent some time, went to the States, and then spent 2 weeks tagging along with Shirley. And that's where I learnt the most clinical stuff ever from a movement point of view, because my first week there she sent me a lot of stuff as well. And then my first week there and that was before she was doing tons and tons of lecturing. So I was there for 2 weeks where she saw patients every day for 2 weeks, and I got to tag along. And the first week was very much, she'd tell me what she saw and then explain what she was going to do about it. And she'd sent me a lot of stuff to read about before that as well. It was all making perfect sense. But then the second week was she got this patient to do a movement thing, and she had to look at me and says, well, what'd you see? Okay. Oh, me. Oh. And then what would you do? And so that what did you see and what would you do became a very dramatic learning curve for me. And I really appreciate that Shirley taking the time out to let me ever do that, you know, with her as well.
Mm-hmm.
And so, but that's when it all started to come together. And then so going back to Queensland then was when we started, that's when we started thinking about integrating the Yanda and the Salmon stuff together a little bit for the undergraduate courses. And that's at the same time was just happened to, you know, like it's like the stars lining up. Was what all the research that Hodges was starting to do on the local muscles. So we had the global muscles, 2 joint mobilizers, 1 joint stabilizers from Yanda's perspective and Shirley Summers' perspective, coming in different ways. Yanda mobilizing the restrictions, Shirley controlling the compensations as their key philosophy. And then local muscles coming in on the back of that just happened to be, you know, it's one of the things I did a presentation on once, and one of my key messages was if you happen to find yourself in the right place at the right time, don't leave. and that was just when that all started to come together, you know. So
the benefit of timing, which is absolutely relevant for our conversations around those translation management role muscles. What we describe as sort of locals within the system. So we're talking now sort of what, mid-90s?
No, so that was sort of the mid-90s, because in the middle of that, because we'd started putting the Salmon and Yanda stuff together as an undergrad thing, but then I moved to the UK in 1991, and that's when we started doing sort of because there was a physio up at Newcastle who'd come from Australia, and had heard I was doing some of these courses. I was doing them outside of the university, teaching this bit of a blend of Salmon and Yanda sort of work. And then she heard I was in the UK, so she said got me to come up and do one at Newcastle. That was the first course I did in the UK, and then that got a bit of a spin on it. So, but that was based on the Yanda and Salmon work. And then back in the and that's when we started doing a little bit of that work. And then I sort of that's when we started sort of putting together a bit of the Kinetic Control sort of stuff. That's when we started doing stuff with Mark Sylvester and Ruth Jones and Sarah. That was the group where we started teaching a little bit of this stuff. And then we really started integrating the local stuff when I went back to Australia for 6 months in the mid-90s. And then came back, and then that's when we added in the local stabilizer component to what we do as well.
Okay, so the context is so far, the sort of summary so far is we've got sort of finishing undergraduate, working clinically, then having this exposure to Yanda, then Shirley's work, and then starting to make a hybrid model, a version that's bringing those two things together, plus the work of Hodges with the onset and the timing component with those other structures, and then starting to deliver this as something which was Kinetic Control.
Yeah. And like what we started doing is, one of the things I found when I started trying to teach other clinicians the way that Shirley used to do it in her early days then, because she used to blend in looking at sort of controlling like if you bend forward, if your hamstrings are tight, you overflex the spine. And the way that she was trying to control the spine, she was also doing the inner range, training muscles to do the inner range work at the same time. And I found it difficult to teach novice clinicians that whole concept. So that's when I started trying to I can separate these things into two blocks. One is the sight and direction, what we call dissociation at the time. So prevent the flexion in the back while you flex somewhere else, and usually where that restriction was. And then do the global stabilizer, inner range holding, as a separate section. So separate them to make it easier to teach. And I think that was because bit of the ADHD and dyslexia stuff that I had, I found that an easy way to explain it as well. And so that became a key part of the Kinetic Control courses, where we separated those things, and then separating that started to make it popular because it was easier to teach people the chunks of this rather than try to blend it all together into observing a movement pattern and correcting the whole pattern in one go.
Okay, so we've got then this now delineation, the coordination efficiency component, the segment, and then the adjacent segment. One part is no observable movement, move the adjacent to the benchmark, and it's a test of control. Can you, or do you can you prevent the observable motion occurring? Uniplanar, it's not supposed to be replicating function. It's a test of coordination to inform whether you've lost this ability to show dissociated movement. Can you do this as a task? Yes or no? Do you have this coordination ability?
Yeah.
And alongside that, separating off this ability to show a clinically relevant muscle test, where again you are using the muscle classification model to infer recruitment efficiency that's also length sensitive, length dependent, and not just testing strength of this structure, but markers of recruitment efficiency, again, based on that model.
Yeah.
And differentiating these two strands. And we still see this now within the KC framework of muscle synergies and then coordination efficiency. Still present.
Yeah. And separating it, that makes it easier to teach. And it's also clinically puts it into the framework. Yeah. So when we first started teaching, because back in 1995, that's when we started, because I was teaching these courses got really quite popular, and I was running out of, and I didn't have time. I still had to do some clinical work somewhere along the line. So that's when Sarah and a couple of people who'd done the courses a few times were looking interested, and they were really interested, and they were motivated. So Sarah, and there was also Mark Sylvester and Ruth Jones at the time. And I said, look, if you guys have come on the course a couple of times, we can either assist me. If you come and assist me on courses, then we can then put more numbers in. And then after a couple of them, we can teach this by yourself. But that was the time also when there was the Mulligan course and the Mackenzie course, and then so we needed to come up with a name that people knew that no matter what course you're doing, you're getting the same course. And I wasn't keen on a Comerford course at all, and it didn't reflect what we're doing. And so so Sarah and Mark and his wife Michelle, and then and Ruth, we were sitting down sort of with maybe a couple of bottles of red wine again, thinking about what are we going to call this. So we wanted to have a name that no matter who taught the course, you knew you were going to get in the same content and the same information. Yeah. And so that's when we came up with the name Kinetic Control, because it seemed to fit about movement and control were the two key things. And so the name Kinetic Control, so that the whole aim was that if people, no matter who taught our course, you were going to get the same process, and we wanted the name to be relevant to what we're teaching rather than just stick someone's surname on the front end of it. So that's how Kinetic Control came about.
Were you ever tempted with kinematic control?
We hadn't thought of that at the time, and kinetic was 2 syllables rather than kinematic, which is so 2 syllables, was roll off the tongue a little bit better.
Yeah, okay. Yeah, nice. Yeah,
and it's
all right.
And nowadays that might be more appropriate, but it'd be
I guess it's tricky. So I guess there's a qualitative kinematic approach to the observation component, but because there's still infirming recruitment efficiency, so there's still the kinetics produced by those structures that produces the movement to occur. So it still seems relevant. I guess if the IOC sort of define injury as the result of kinetic energy being transferred to the body, okay, fine. So kinetics in there. Okay. So we've now got to the point then where kinetic control exists. It has its name, it has its pathways, and it's now rolling out. There's a team delivering this, and it becomes now global.
Yeah. And sort of in those early days, back in the mid-90s, we were doing lots of teaching in the UK, but also, I'd been asked to do some stuff in Switzerland, so we were doing in Switzerland, which then migrated into a little bit of a little bit of work in Holland as well, and then we also started getting some interest in a little bit of Scandinavia. There's a few different places around. We started getting a bit of interest in that because Mark and Nora Musgrove, who set up Physio Tools, they were actually based in Southampton at the time, where Ruth lived, and so we sort of got linking with them, and then they started looking at, so can we put this into their program, some of the exercise stuff into their program, and then because they were strongly linked in Scandinavia, that started getting us a little bit of work into Finland and Sweden and Norway as well. And Norway was quite close to Scotland, where I was living at the time, so it was easy to cross over. And so it just started spreading a little bit in Europe at the time too. And so we started doing more stuff in Europe. We got some exposure at the IFOMP conference in Portugal, which is where we sort of presented our movement classification model. We presented a couple of conferences in the UK, but this is probably the biggest one where we presented that for the first time. And it's where we sort of gave the whole idea of the local stabilizer, global mobilizer synergists. When we combined those two models and published that in 2001, that sort of was sort of giving a bit of a framework, and that model has still stood the test of time. But also what we did also is that one of the most mistakes we made when we first developed that model was thinking every muscle will fit into one box. And how wrong we were, It took a while to work out that some muscles sit only in one box, like, for example, transversus is a local stabilizer, and then hamstrings is a global mobilizer, maybe gluteus minimus as a global stabilizer, thinking that, giving that framework. But there was lots of muscles that would multitask, could do more than one thing, Gluteus maximus was a classic example. It had some fibers that only control translation in the sacroiliac joint. So it's had the single joint fibers that cross the hip joint of the global stabilizer, but the superficial fibers attached to the ITB and across the knee. So gluteus maximus was the first example that where we make it clear that some muscles do more than one role, and some of them do all three of those roles. And so the IFOMP conference in Portugal was where we first came, because a lot of the European languages give muscles gender. We gave muscles gender for this conference, which was a bit of a laugh at the time, but it actually worked out really well, because the one joint muscles are single task specific, good at doing one thing, and when something goes wrong, the same thing goes wrong every time. Male muscles. And then the female muscles were the multitasking muscles that could do more than one job, and we're happy to do more than one job, so long as no one tried to tell them how to do those jobs. And so that was a bit of a sexist sort of theme at the time. We could get away with it back then, but it was the idea of giving muscles gender and then giving them that multitask, single task role really then took off as a bit of because there were limitations in giving muscles a role, and then every muscle had to sit in one box. And so now we started to understand that the neurophysiology of some muscles, and that's where the central nervous system really makes a difference. Central nervous system drives these muscles, and so one of the things that we thinking about is that we then started, and that was Sarah was driving a lot of that, is that, well, how does the motor control system, how does the neurophysiology, we've got the central nervous system making these muscles, but how can the central nervous system make a multitask muscle do one job more than another job, or switch roles depending on the task and the requirement at the time?
So that
made
discrimination between synergists, the weighting, the relative weighting contribution between synergists, and how that can change. Yeah, okay.
And learning that synergists are more complicated than we thought, than just being one joint mobilizer, one joint stabilizer and two joint mobilizers.
I always find with the classification model, it's a fantastic compass to, I say it helps you navigate a lot of the challenges of trying to make decisions about what to do when you see certain things, what you're going to do, what are you going to do? Yeah. So it gives you a way to navigate that. My sense is that we're going to continue to discover it gets ever more complex.
Oh yeah.
But this is indeed. But this is a great model and still the best one I've seen to try to address that problem.
Yeah. And it stood the test of time. So we published that first in 2001, and we're now 25 years down the track, and it's been modified, it's been fine-tuned, the basis is still there, and then we're developing more skills as how to assess different elements of this, and how to retrain different elements to restore optimal recruitment and optimal efficiency. So
the 2001 papers were seminal in terms of introducing this to, now I guess, the literature more broadly. And then the literature continues throughout the next it continues, but also significantly through those next 10, 15 years alongside the delivery of Kinetic Control.
Yeah. And then, and over that time, Sarah and I were the core people left behind with Kinetic Control. And then you've now been recruited in, so you're now part of it. I was just trying to remember what year did you officially come back, join the team, Lincoln? It was
my exposure to Kinetic Control was hanging out in a gym and meeting some physios that had done this Australian course, and I said, well, this sounds like it makes sense. I don't understand it, but there's a sort of structure and a systematic way of doing things, and it's there's a logic there that I'd really like to understand and get my head around. That was about 2001, 2002. And then I got exposed to Performance Matrix 2005. And then started getting involved on delivery side 2010. And then got more involved on the back end side of things 2015. So, and then started to get involved with, I guess, the writing process from about 2013, 2015 onwards. Which is been incredibly developmental to again try to apply it, I guess, to specific problems. So hamstrings, for example, has been one of the factors, and also to think about the coordination testing from this phase relation idea of in-phase, anti-phase motion, and saying, can you prevent in-phase or anti-phase motion, and can you keep the proximal segment as the dominant or the distal segment as the dominant action, and using those types of analysis techniques with it.
And that's been very that's part of the development of how things have just keep moving on all the time too, and so I think there's been a thing. So the core things is that, and one of the things I think we're seeing nowadays is that back when the local muscles started up, everyone was assuming that, because everyone with back pain has a change in the local muscle neurophysiology, everyone just assumed that retraining the local muscle neurophysiology would cure everyone's back pain, and that was again naive in the extreme. But it took everyone a long time to learn that as well. And what we now know is that, and so one of the things that I think, one of the strengths of the Kinetic Control framework is that we've got this idea of looking at the coordination efficiency, so the ability to look at the site and direction coordination control, and then also look at the synergists separately. And one of the things that we are seeing is that when people have more acute pain, identifying the uncontrolled movement or the uncoordinated movement, that relates to the pain producing segment. So if we see excessive flexion, producing flexion-rated pain, teaching people to do the sight and direction, coordination, control of that is a nice way to start changing symptoms. So one of the ways that we can, one of the ways that I think is the best to sort of, for people who aren't so familiar with this, or when we're pitching this to people who are looking at where do we want to start with the kinetic control framework, looking at that, because that tells us about movement coordination and patterns of movement that relate to pain, and that's where people often come to us as clinicians first up. But it was also when we're looking at it's not even just that. When we're looking at movement control for performance, controlling movement's still important for performance, even if you don't have pain. And so sight and direction stuff is the way we want to start looking at the control, the sight and direction coordination work. And then there's benchmarks for what we can, and we've been working at benchmarks for a long time. But then the synergists, what we're seeing nowadays is that unfortunately, a lot of people will use the sight and direction work to get control of symptoms, and they think they're done. But recurrence, this is the future for us. This is the future for kinetic control, and this is the future for physiotherapy in particular, in general. Okay, recurrence is so poorly managed that most governments aren't even trying to keep data on it. Yeah, but there's clinicians out there, there's researchers measuring, back pain. If you get back pain, 80% of people after their first episode are going to get 80% of people are going to get recurrence in at least the first year, and probably for 3 years, every year. Okay, neck pain is high. It's 60-70%. Shoulder pain is 50-60%. We know that if you get a musculoskeletal pain mechanism, whether it's traumatic, whether it's overuse, whether it's insidious, whether it's whatever, whether it's from other mechanisms, okay, recurrence is high. But most health systems just think, you go back with the pain again, it just starts off as a new episode, a new pain. You don't start thinking, it's not that we haven't managed this one from the first time around. It's the first problem is still coming back. And what we see nowadays is the research is starting to become more and more clear that looking at the stabilizer mobilizer synergies, the global stabilizers, mobilizers, where those synergies change because of pain, inhibition of the stabilizers, protective over recruitment of the mobilizers. Okay, addressing that is something that can change recurrence. And also the local stabilizers that we used to think would help the pain. It's not so much helping pain in the current episode. We're seeing that retraining and recovering the local stabilizers early in the management, or before they get tons and tons of recurrence, is a way to help decrease the incidence of recurrence. So the theme, I think, where kinetic control has a real strength for the future is looking at our sight and direction coordination control work. Okay, and we've got really clever ways of assessing that and really clever ways of retraining that. But that's early and simple symptom management, particularly for nociceptive pain mechanisms rather than the nociplastic or the neurogenic sensitization mechanisms. But for a lot of people, that's the most common pain mechanism out there. You've had an injury, you hurt your back, it's provoked by one movement, relieved by another. Perfect. But then dealing with recurrence is where the future is, and that's where looking at ways to assess the efficiency of the stabilizer mobilizer synergies, recovering what we've got, and then looking where the local stabilizers fit in there too. And then and people often have combinations, or one is a bigger problem than the other, but assessment of those synergies is what we're really good at, and retraining those synergies. But that's where the research is showing changing those things is having an influence on recurrence. And so
the time course of this then is that there's an episode of pain for whatever reason, but then if we're going to we need to sustain an output in life, so we still find a way, but that finding a solution to life might come with altered synergies, as in altered from what they were before. Not saying it's wrong, just saying that those synergies can change, but downstream of that, we then may suffer recurrence because of the change in that synergy. So this, it's a little bit like the 2018 paper, the dynamical systems idea that over time things change. We've got a dynamical system, and we need to be considerate of that. We can't just think that assessing this person at this discrete moment in time tells us everything we're going to need to know if we're not considerate of the past, but also considerate of what they're doing now is going to be influential on the future. So there's a time series we need to consider of here. And the classification model gives you a way again to manage that. So that's harking back to the strength of that model. You were talking before we started recording about what you've been developing, maybe that's going to sort of set the scene for where these things go next. So a little bit of an idea of where are we going next with this?
Yeah. Okay, I think there's a couple of key areas where we're going next. Okay, one is looking at, and we've already on this path, is looking at performance and prevention. So the matrix which we've developed, it's been developed around, and I think this is just going to build more and more as we go along. But looking at sort of, again, movement evaluation, looking at the quality of movement, looking at these tests of movement quality, movement coordination, as identifying risk factors in sort of, number one, potential for injury risk, but then also for optimizing performance, because it's the whole idea is that when we're generating force for performance, it's got to generate across multiple joints, and if there's one loose wobbly one in the middle, then there's two implications of that. One, the loose wobbly one's more likely to develop tissue stress and develop into an injury. But also, number one is that the movement's not efficient. You're not propulsive, you're not explosive, you can't generate force, or you're trying to control that movement. You're going to fatigue the muscle work trying to control movement there. You're going to fatigue faster. So that's one thing that's obvious, and we've already got that process in place. But I think that's going to gain some traction again over time. Okay, I think it was developing quite nicely. Then COVID put the brakes on the whole world looking at stuff. But I think that's going to make a resurgence again, looking at sort of that whole framework.
So just on that point, before we move on to the next point, is that the direction specific feature now of people looking at movement tasks is certainly coming back.
Yes.
So within the area of research I'm involved in, there's a lot of focus now on specific inclinations, angles, motions of pelvis, with respect to particular injuries. So this is one of the issues with this, is that everybody assumes that one direction's the problem, as opposed to So as opposed to assessing and identifying for that person that, well, for that person that's a problem, but it might be the exact opposite problem for somebody else.
Yeah.
So there's a need to be able to classify the direction rather than just assuming that the direction's the problem before you assess it and identify whether it is a problem. So it's good that directionality is in there rather than it just being, you need to make it stronger. That's good. However, we need the sensitivity of direction. That needs to come back. Movement quality is a really interesting term, Mark. So there's a lot of definitions for it.
Yeah.
And it's a little bit like that other term that we always talk about as well, which is core stability. Again, it has so many definitions. It's almost meaningless because there's so many definitions of it. You can, if you want to mean it's this, it's that, then okay, fine.
And also along that line, Lincoln, when we wrote the book, Kinetic Control, the management of uncontrolled movement. Uncontrolled movement is something that has so many other definitions too. Like it can be an upper motor neuron problem too. So I think terminology is something that is a thing that one phrase has 50 different meanings depending on where your background is. And so I think that's so. And so I think trying to become a little bit more specific, but then even as we become more specific, we're still going to run into that. This is going to be a never-ending problem. I think the whole idea is that we just have to explain what we're doing a little bit more. It's not going to be
infinite regress. The infinite regress of definitions, as in definition. We'll define definition. It goes on. So and each definition needs a word to define the word you're describing. I know. So movement quality, and again, I've written something about this of saying, well, do you mean a movement characteristic, or do you mean a movement taxonomy? Do you mean a quality as in a property, or do you mean a rating of movement? And if you're going to rate movement, how are you going to rate it? What's your criteria? And this, I guess, led us to the whole thing about, do you have control? Well, what's control? Well, when asked, can you display choice in how you move? Yes or no? Rather than just assuming that you watch somebody perform an action and they have choice because you've decided they have choice and they have control. Okay. So terminology, an endless conversation, but we're touching on that there now. So other points about moving forward. So we sort of move beyond then this sort of focus on performance. We've talked about directionality in performance and assessing for that. So the other point you're going to make.
Yeah, the other one is that, like, one of the things is that, pain is what people come to clinicians for. to the majority. That's the bit that gets them off their bum and saying, I've got to do something about it now, because they'll put up with it until it sort of starts to interfere with their what they want to do and need to do, and how happy they are. So, and I think one of the things is that I know that the ISP are looking at reviewing the classification of different pain models and pain mechanisms. And very much they've had in the past this whole idea of nociceptive pain, which is the inflammatory mechanical tissue injury pain, then nociplastic pain, which has more neurocentral and neurogenic mechanisms behind it. And then also behavioral and psychosocial mechanisms that have also been sitting in there for a long time. And I know that that Paul Hodges is on that committee, and there's quite a bit of review that's undergoing at the moment, and they're going to be publishing some nomenclature again, names, but giving it a little bit more description and classification. But I've been working on this for a little while now, and then looking at this whole idea of different pain mechanisms and how we can clinically identify them. And so looking at sort of nociceptive pain, which we understand very well, and everyone has a bit of a handle on that. But then what we now call nociplastic pain, but whether it's centrally mediated or peripherally mediated, so examples of peripherally mediated nociplastic pain will be trigger point pain, neurodynamic sensitization, or neurofascial interface pain. Whereas the central sensitization is more everything's got is allergenic and hyperalgesic, and everything hurts, and there's nothing that's really relieving. Then there's also central and peripheral neuropathic pain, so pathology in the pain. So and there's a bit of a crossover between tissue injury within the nervous system, like nociceptive pain, but within the neural tissues, peripheral and centrally. Then there's also behavioral, psychological, social, and environmental components, all tied into these things. And so I've been looking at that for a little while because I see a lot of people with chronic, recurrent, and persistent pain, and they've all got combinations of these things. And sometimes one is more dominant to the other. But movement is a way that we can manage. Movement has positive and negative inputs on all of these different pain mechanisms. And so working out sort of what sort of things are going to be what sort of things are going to be helpful, which sort of things are going to be negative, getting people to move in the different directions. And at times, as one mechanism changes, then another one becomes dominant. So it's not just sort of the same pattern. It's in a state of flux. And so I've been working on that, and as part of one of our courses on the clinical judgment, I'm looking at sort of the whole framework of sort of how we might integrate movement into pain and pain mechanisms. It used to be sort of a couple of hours of a 2-day or 3-day course, and now I've sort of got a huge. What was started was going to be a webinar. I've been speaking to Paul Hodges about it. We've had a couple of chats. I've gone through this whole thing with him in quite a bit of detail. And he suggested that I should be doing a PhD on this. So I'm looking at that. But the whole idea is not just for clinicians to be able to identify and classify and make a clinical diagnosis of which of these pain mechanisms we are present and which combinations they might have, but how movement has positive impacts, and also how to avoid the negative ones, and then looking at how movement can make long-term positive changes, and also accepting that a lot of people with chronic and persistent pain are not ever going to be totally pain-free. You're not going to turn, I think one of the models we want to think about is that depending on if we think about people as being a motor vehicle, okay, there's a certain time when you run out of warranty,
right.
but you might be in 1960s or a 1970s sports car and you're out of warranty. But so long as you keep up good maintenance, you'll run well. Even though you may not be winning the races anymore. And so this and also you can have a car crash. You can be a young car and have crash, and so then you've got to do some repair work, and so that analogy is quite a useful one to work out, because rather than telling people you're getting old, you're just out of warranty, and you need a bit of you need to look at how we're going to keep your maintenance up.
Yeah, I mean the idea of this, because you mentioned the word movement, and already this sort of it has so many different interpretations.
Yeah,
and we're looking at specific characteristics of movement, rather than sort of just do some movement and everything will be fine. It's specific markers of movement, and then how that's changed, how it's first interpreted to be changed respect to these particular presentations you're describing here. So it's still very targeted, it's still very systematic in how it's delivered.
And so depending on if you got a nociceptive pain mechanism, then a lot of the stuff that we already talked about, we have it built in, and that's 80% of people who come to a physiotherapy clinic. Not all the terrible pain people. They're not turning up every day in the clinic. 80% of people who turn up to a physiotherapy clinic have mainly nociceptive pain, with maybe a little bit of psychological, little bit of social, but maybe little bit of nociplastic sort of stuff sitting in the background. But identifying that. But the people who've got the really problems are developing other features. Okay, we need to understand them. But then the movement retraining that we might do to help manage one person's pain mechanism might be different for a different pain mechanism. So then the idea is that how can we optimize that? And that's what I'm doing a lot of work on at the moment, is looking at. So and it's all about not necessarily just making you stronger or more flexible, though that can be part of it for some people. Okay, but it needs to looking at sort of how we can coordinate patterns that we're not using efficiently. Are there things that are creating stress on the tissue system? Can we make it more efficient? And how do we make it more efficient when you've got allodynia, when everything hurts? So and if you're scared of movement, if you've got, so by the time you get some psychological fear and anxiety, fear of movement, okay, we don't want to tell people that So one of the things that is a useful thing about is that they're scared to move. Their brain is in protect me, So this is danger in me. I need to protect it. And then and so we can let them psychologically work with that, saying, I don't want you to move where you hurt, okay? Because that's what everyone else has done, has made you worse. I don't want you to move where you hurt. I want you to move somewhere else. And we're going to try and find something that doesn't make it worse. If you can, but what we don't tell them at the minute, because if they're scared of moving, if they're scared of doing exercise where they hurt, we don't need to tell them that to actually not move where you hurt, to protect where you hurt. You've actually still got to activate muscles in that area. And but when we just get past the fear of actually just muscle activation and muscles being involved where you hurt, so that while you're moving somewhere else, and then we're starting to change the way that they think about movement. They don't think they have to actually produce force or movement where they hurt the most. But they just don't have. But they don't have to be fearful of actually that muscles working where they hurt the most. And so there's a lot of ways we can get into this, and looking at this in a lot more detail, and then targeting sort of how can we deal with this pain mechanism? What sort of strategies might not just what movement you might do, but how we might pitch that movement. It's like selling a car. We've got to make it sound the right way, that it's acceptable, so that you're not going to do what you're really scared to do.
And how to make sure that people don't think that because if there's somebody with fear of movement, that this approach of, say, a direction control approach, how that's not going to sort of feed into that, going, oh well, don't move this, but do move that. So it's trying to make sure that people are clear that they're different approaches. And this is actually trying to manage that.
And the terminology and the words we use, have got to resonate emotionally with them as well. So if people have these patterns, and also there's social things. There's things that people expect to do in their work life, or the family structure they're brought up in, or in the community structure that they're brought up in. There's environmental things. They're all different parts of the puzzle. And then the movement strategies and the way that and even though we might use a similar movement strategy for something, how we explain it is important. So how it makes sense to the person on the receiving end. So we've got to make it person-centric, as opposed to getting everyone just to do the same thing all the time, And so so understanding how they think, what their problem is about, how they feel about stuff, and then sort of pitching what we want them to do in the framework of what they understand and what they think is good for them, what they don't, and then they can learn to experience a safe safety in me rather than danger in me.
So there's a coordination profiling, there's a communication profiling, so that these align, so that how it's delivered works with how they need to hear it, and also what they need to do.
And understanding getting a clinical framework of picking out which of these mechanisms they've got gives us a bit of a head start about what sort of movement strategies we might want to put in there. And also how we might then explain this movement strategy to them, how it fits in with working with the pain mechanism and the consequences of that pain mechanism as well. So I think the nuances in that are going to be what we're going to get good at, and then we're going to see this making a patient specific approach. And so, one of the things I have in this presentation that I was speaking to Paul with, it was, the biopsychosocial model, which has been around. I'll just read to you a couple of one of the slides I've got here is that the term biopsychosocial model has been misappropriated, okay, by a variety of biases, and maybe too damaged by social media and opinion, and a lack of truly integrative practice. Okay, so I think it's too much damage to recover from. And so individuals with chronic pain and recurrent pain have a mixed bag of confusing presentations and diagnoses in inverted commas. Okay, pain is multifactorial, it's multimodal, involving components of tissue injury, damage, inflammation, their biomechanical stressors, okay, and biomechanical sensitization, but combined with elements of nociplastic sensitization, neurogenic sensitization, and that can be peripheral and central, amplified by a complex overlay of psychological, behavioral, emotional, social, and cultural influences. Okay, where do we go from here? Okay, and how do we move forward into an inclusive, integrative, multimodal framework backed by science? That's where we got to go. Okay, and so what I'm suggesting is that we're going to be moving into something more of a multimodal movement health framework. Okay, which can incorporate changing pain mechanisms, rather than treating the psychological or bio. Okay, and unfortunately, the bio has been neglected in the literature for the last probably 11 to 12 years. There's been really high quality research on looking at the psychological and emotional and behavioral components, but when you look at the patients in those studies, they're the worst of the worst. They're people on high opioid or central neuromodulator meds. They've got significant amounts of psychological distress, anxiety. They're moving away from social interaction. Okay, that's not the most of the people we see on a day-to-day basis, but they're the people who respond well to that psychological, social sort of management process. But the bio has been left behind for a long time too. And what we do, we have a very clever way of dealing with the bio component and integrating it into the different pain mechanisms.
The bio component in what I'm looking at is very key, but it's a specific component of the bio, which is very much driven by either how much you've done in terms of this, whatever this term means, of load, workload, or force production. So there's still probably those other components of that model you're describing have yet to enter a lot of the sports injury components. And we're still at an earlier part of the bio model.
And that movement evaluation model for the 2018 paper with Bart, and you got, and all of us, that's where this is going. Looking at sort of looking at the movement control and coordination side of stuff, but then adding in sort of the biomechanical evaluation of movement efficiency, and then blending them all together. So that paper, I think, is where a lot of the future for sport and performance and injury management and risk identification is going to come in as well.
So the 2018 paper with Bart was really interesting because we were coming at a similar problem from different perspectives. And there was this in the model that's arrived at the end of the paper. We identify that you can assess movement by looking at so-called preferred or self-selected tasks, but you can also use the approach we're describing here more, which is this cognitive movement control testing, which again it's an ability of the person compared to observing them perform a sports action, for example, and testing that, and testing characteristics of that. There might be risk that you can identify within the cognitive movement control tests, rather than it just being a way to identify that the person is not going to be responding well to coaching. So it's beyond, I think, what we described in the paper. I think there's some parts there that I would probably sort of think to revise in that, which would be, but that coordination pattern that they're displaying might also be a risk factor if they've got enough of them.
And that leads me to one of the other areas where I think it's sort of is where we're going to be. It's almost like revisiting the past. One of the things that I've seen also is that yeah, back in the day, if we want to use that term, okay, it used to be thought that restrictions were a significant risk factor for injury in sport, or contributing to predicting injury risk in sport, and then try to get people more flexible and mobilize restrictions would decrease injury rates in sport. And when people have done studies that they show that was clearly not the case. Mobilizing restrictions and making people more flexible and mobilize that did not decrease injury rates when they did it in studies. A lot of those studies were done in the military because they were in like match groups as well. But one of the things that I believe, and I think this is where this is going to come back, okay, because everyone I know who works in sport still finds, and they still all have a gut belief that if you've got a restriction, it's still going to give you a problem. And so we can still argue we want to mobilize restrictions because it might have an effect on performance, okay? Because limited movement might equal limited performance. So everyone is still working on these restrictions, okay, even though they can't prove anymore that, or they can't say anymore that they might decrease injury risk. But where I think the real link here is that, and this is where our movement evaluation for the sight and direction coordination comes in, and we've got benchmarks and the benchmarks, and that's what we talked about in that 2018 paper too. That if you've got restrictions, one of the things that we do know is that people will compensate for the restrictions to maintain functional performance markers. Okay, but when we test all those people who might have restrictions somewhere, and they compensate with some movement somewhere else to maintain functional performance. Okay, not all, when we test their ability to control the coordination efficiency to control the sight and directions of those compensations. A lot of people pass those tests and a lot of people fail those tests. And so where I think the real link is if you've got restrictions and you compensate for them by moving more somewhere else to maintain function, if you control that compensation, your injury risk is low. But if you don't control the compensations, which we have tests for, your injury risk is likely to be higher. Now that has never been tested. Because the things is everyone just mobilizes the restrictions. Look, do we see injury risks decrease in sport? Okay, but one of the things that makes me believe this is one of the things that when Andy Barr was working with the Knicks, when they first started putting in the basketball matrix, because while I was working with them at the time, we've developed the basketball matrix, the screening program there, which is all based on sight and direction evaluation of multi-joint movements and multi-directional movements. But one of the things that I think Andy says off the record, so I don't know if I should be saying it here, is that in the first season, after implementing these assessing players and then building retraining programs around this risk profile that they were developing, they did decrease the injury ratios in that first season, and they had better performance markers. So I think so Andy can correct me if I got that wrong, but I think that there's a bit of politics about we can't sort of give out names and numbers and that sort of stuff as well. But I think but I do remember him talking about that at the time, and we were looking at that at the time when we were developing the basketball matrix screening system, and I think we've all seen other case studies of where injury risk has decreased as well, but I think that's where we're going to see again restrictions coming back into the deal. Okay, giving manual therapists a reason to live again. Because
the one of the problems is the focus on tissues at risk. So there's the idea that if you, again, I'm going to talk hamstrings. So if your problem's hamstrings, let's test the restrictions in the hamstrings then. You might want to go a little bit beyond that, because if they've got restrictions somewhere else, it might be that they pick up the slack. They have to get around the planet by using other strategies. It might be those strategies that are associated, linked to the risk we're describing. So getting beyond the tissue at risk would be good. Thinking about the whole system would be good. Practitioner perspectives are still test range of motion, and they'll still get interventions to address it, even if the evidence isn't there, because they still believe it.
No, and I think where the direction needs to move is that we're all clinicians and trainers and coaches and exercise physiologists. Everyone will find restrictions, and everyone can mobilize the restrictions. But the people who are at really risk is that if they've got the compensations that they've been using to compensate for those restrictions, if they don't regain control of them, if those those movement coordination patterns that are we might consider to be suboptimal or inefficient. Okay, if they still persist after we've got the restrictions back, what we've just got is a flexible person, but they're still not getting the coordination control of their risk factor. And so just mobilising the restrictions has been shown to not be the answer to decrease injury risk. We've got to find, but if you've got restrictions, mobilising those restrictions means that you don't have to compensate somewhere else anymore so much, but you still have to teach people to control those compensations in some way or form. And whether that's with synergy work or with sight and direction work, there are strategies to do that, and also strength training, high threshold strength training can be part of that as well, controlling those compensations depending on the sports or the tasks people are returning to. So I think that's going to become a little area of the future again. Yeah, people will be working on restrictions because they still want to do that, but then what do we do associated with that? And even that example, the hamstrings. Yeah, one of the things is that if you go back to Natalie Russell's paper on dancers, she found that 2 key tests of movement coordination control, sight and direction control, could predict risk of lower limb injuries in dancers that had nothing to do with the lower limb. They were lumbo-pelvic control tests that the dancers because it wasn't hypermobility that predicted the risk of lower limb injuries in dancers, back and lower limb injuries. It was the inability to control the lumbo-pelvic region while they did hip and lower limb movements. So the dancers who had poor proximal control of the lumbo-pelvic area were the group who had the higher risk of injuries. And it wasn't the hypermobility in general that was a belief at the time. But what was very interesting about that paper is it wasn't tests of controlling the lower limb that would predict the lower limb injuries. It was the proximal control above it. So it's going to be a little bit more complicated than we thought. But that's where things like the matrix process looks at that. It's not just assuming you've got pain here and you're going to do that. It's going to look at control, a battery of control tests, and you'll find those problems wherever they'll come up in assessment.
The idea that there is a anatomy is us describing bits of a human body and saying that's a segment, but it's a person and they operate as a system in a bigger system. So the idea that it's going to be correct that assessing one region is going to find a problem at that region, that's where the injury is going to happen, it's too simplistic.
It's common. It's a common finding, but it's not necessarily the answer to a complex problem. I
think for a little while we've had a lot of focus within sports injuries, which again is sort of where I'm operating more, but a lot of focus, as you know, eccentric strength training. We've been fixated on this. However, we do now have an increase in literature that's starting again to start to consider these different characteristics of movement. And I mentioned earlier on the hip and lower leg movement screen, and this has been devised alongside the work of Maria Stokes, yourself, and Nadine Boysen, of course, alongside Sarah as well. So this is positive. They're doing lots of nice stuff around intervention, as in they are testing, delivering interventions, testing again, and showing change in test. That's interesting, but also they're showing alongside this, there's change in injury rates. So rather than showing that it's associated to risk, they're doing it indirectly by showing change in testing outcomes. So again, a positive thing in the world, based on the idea that, well, if these characteristics of movement matter, at least this is a way to consider.
So I think that's what we need. We need a couple of simple things to give us the direction of, okay, now we have a problem and we know sort of roughly where the problem is. Okay. And then I think one of the things that has been in the past is that we've just been trying to pass the test. So if someone fails a test, rather than sort of, just trying to work out, well, how are we going to fix the problems that we see in this test? People just been practicing the test until they pass it. Okay. And that's not necessarily fixing the problem. So I think some of the ideas of these sort of tests that we've got in that hip lower leg screening thing, they look for patterns of problems, but then the idea is that it just gives you, okay, it's how we interpret that test. We've got a problem of hip rotation control. We've got a problem of spinal control, or sort of a problem of femur versus tibial foot alignment, that sort of stuff. And so once we see those things, then we can go, okay, well, what things might contribute to this? And then we can look at retraining. Which muscles might be used? Which muscle synergists might be used for controlling this? Are there other muscle synergists that might be lacking extensibility and forcing us into these patterns of movement? We can look at that. Are there joint restrictions that might be contributing to some of these things of the patterns? Is it simply that we just need to look at patterning? Can you control one area while you move another? And so that, I think, is having a series of tests that we can then look at. But then what we need to look at is then how are we going to interpret what we see in this test? And that's where people need a little bit of advice. We can sort of look at, when you see this, it means this, or when you see this, it means this. Okay, but then there's more than one ways. There's multiple ways what we might do to try and deal with that problem once we've identified there's a problem. So practicing a test you fail until you pass the test has benefits, but it's not. But I think there's more to it than that. We've got to think about what are we interpreting, and what other things can we do to make that better.
Yeah. So there needs to be then good reasoning behind the interpretation of the outcome of the test, and
yes,
how that then directs practice. Okay, which is what Kinetic Control does, and has consistently done for these 30 years. And it sounds like it's going to get more refined to do that better.
Yeah, I think, and that's like so. And one of the things that I think is, I think we should all be proud of that we've developed as everyone who's been involved in Kinetic Control and developing it, and as we've gone along, is that the core principles come from important people in the past. Yander's principles, Salmon's principles, blending them together, and it's interesting that what we've done is try to then add in some of the other local stuff, then sort of come up with a muscle classification model that fits within within the Yander and the Salmon frameworks and the local stuff, and that because that has really stood the test of time, and having some basic things that are the foundations, solid foundations in terms of anatomy, biomechanics, neurophysiology, because they're the basic components of clinical reasoning. And if we have a bit of a combination of all of those things, we can make informed decisions, and we can also problem solve better. But those foundations, and then looking at sight and direction, coordination, synergist efficiency for the global stabilizer mobilizer synergies, and how they change relative to each other because of pain or affect performance, and then the local stabilizers and how they then affect translation control and how we can retrain it. And so looking at sort of symptom management, and with sight and direction coordination work, looking at recurrence management with stabilizer mobilizer synergies and local stabilizer recruitment efficiency, but then also translating that into, again, performance and movement efficiency, even if you don't have pain. Looking at maybe developing in terms of the lost choices, the patterns that we have benchmark tests for and controls for, the ones that you don't have, but other people do have. Maybe they are weak links in the chain. Maybe they're missing choices that we can then develop, and we're putting them back into people's movement toolbox, and movement efficiency. So there's so many things that we have built, and we're not changing. We're not throwing stuff out so much. We're just building on it and fine tuning it and modulating, and then adding new branches to the tree, so to speak.
Well, we look forward to the next evolution of the Kinetic Control tree, and hopefully this PhD, Mark, could be a fascinating project, and I think we'd all look forward to anything that would come from that. So anyway, Kinetic Control at 30, and there's still plenty more to come. Yeah,
and then one final bit is that the split, the offshoot into the movement science practitioner, where we're just looking at movement efficiency, movement mentoring, and just looking at sort of multi-joint movements, and looking at sort of how we can blend some of those skills we've got in within the Kinetic Control thing. And so looking at just getting people to move more efficiently as well. even if you don't have the same clinical background as a physiotherapist might, or another clinician might. There are so many tools out there, and then but they're all built on the same foundations, and those foundations are strong, and they'll keep us going.
All right. Well, thanks for your time, Mark. It's been excellent to hear all these ideas and the history of Kinetic Control. There's things I've never heard before either there, so that's great for me to understand how this came about. So thank you for that. Thanks for remembering, because I know it's a little while now since those things happened.
And I'm looking forward to the 50-year chat.
Oh wow, aren't we all? Yeah, I'll let the AI do that for me.
Yeah, it will be that way by then. Okay.
All right, Mark. We'll catch you later, mate.
Okay, no problem. Hey, thanks, Lincoln.
Bye.